Hi, good morning. Thank you for the opportunity to present my Doctor of Nursing Practice Quality Improvement Project. So, my name is Phalonne Burin. I go by Faye, and today I will present my projects titled Reducing Mental Health Crisis Readmissions Through Standardized Discharge Planning, a Quality Improvement Initiative. So, this project was completed at Regional Management Care. It's a mental health crisis center, and the project focused on improving transitions of care through a standardized discharge planning process designed to reduce 8-week mental health crisis readmissions. Okay. All right. So, background and significance. Mental health crisis readmissions are a persistent problem in behavioral health care because they interrupt continuity of care and often indicate that patients are not receiving the support they need after discharge. At regional management care, nearly 1 in 3 patients return to the crisis center within 8 weeks of being discharged. So this highlighted an opportunity to improve the discharge process by implementing a standardized evidence-based approach that better prepared patients for successful transitions back into the community. The practice problem identified at regional management care was the lack of a standardized discharge planning process. Although patients received the appropriate crisis stabilization, discharge planning practices varied among providers. So, this inconsistency contributed to missed opportunities for medication reconciliation, outpatient follow-up, and community resource referrals, as well as it increased the risk of relapse and psychiatric readmissions. The baseline of 8-week readmission rate of approximately 30% showed that there is a need for an evidence-based quality improvement intervention. Again, the purpose of this quality improvement project was to evaluate whether implementing a structured crisis intervention discharge plan could reduce mental health crisis readmissions within 8 weeks of being discharged. The intervention focused on standardizing 3 evidence-based discharge practices: medication reconciliation, scheduling outpatient follow-up appointments before discharge, and providing referrals to appropriate community resources. These components were selected to strengthen continuity of care and improve transitions from crisis stabilization to community-based behavioral health services. All right, a big cut question. So this project was guided by a PICOT question that focused on whether implementing a structured crisis intervention discharge plan would reduce mental health crisis readmissions within 8 weeks compared with the organization's existing discharge process. This clinical question directed the design, intervention, outcome measures, and evaluation of the project. So once the practice problem and project aim were established, I reviewed the evidence to determine whether standardized discharge planning had been shown to improve care transitions and reduce psychiatric readmissions. Review of literature. So, before developing the intervention, I conducted a review of the literature to identify evidence-based strategies for reducing psychiatric readmissions. 5 consistent themes emerged. First, Psychiatric readmissions remain a significant national problem because of inadequate continuity of care, often leads to repeated crises. Second, structured discharge planning has been shown to improve care transitions and reduce readmissions. Third, connecting patients with community resources improves treatment adherence and long-term outcomes. Fourth, medication reconciliation is an essential component of safe discharge planning because it reduces medication error and promotes adherence. And of course, the AHRQ Ideal Discharge Planning Framework provided the evidence-based structure for this project by emphasizing patient engagement, medication education, coordinated follow-up, and continuity of care. All right. So we're talking more about the theoretical framework. The AHRQ Ideal Discharge Planning Framework was selected because it aligns closely with the goal of this quality improvement project. So, rather than focusing solely on discharge instructions, the framework emphasizes patient engagement, medication education, coordinated follow-up, and individualized discharge planning. So these principles guided the development of the standardized checklist used during implementation and also supported a more consistent approach to care conditions transitions for adults discharged from mental health crisis center. All right. Methods. Excellent. So this project used a retrospective pre and post quality improvement design to evaluate the effectiveness of a standardized crisis intervention discharge plan. A retrospective quality improvement design was selected because it allowed evaluation of the effectiveness of the intervention using existing electronic medical record data while measuring organizational practice change before and after implementation. All right. So I think this design was appropriate because the project focused on improving clinical practice rather than testing an experimental intervention. Again, the project was conducted at Regional Management Care, which is a mental health crisis center, and included 154 adults discharged during the study period. So we had 80 patients on the pre-intervention group and 74 patients on the post-intervention group. The intervention standardized medication reconciliation, outpatient follow-up scheduling, community resource referrals, and discharge education. Now, just giving you a flow of the methods for project initiation, January to March 2025, and planning and development, April to September 2025, IRB and QI approval, 9/16/25. Then we did the staff orientation and baseline EMR. Then the intervention was implemented 10/20/2025. We had 8-week tracking period to the data analysis, which was completed December 2025. Okay, now again, we talked about project implementation flow. Now we're going to talk about how we came about with the standardized crisis intervention discharge process. So first, adult patients ready for discharge. Second, medication reconciliation, where we review all current medications, we consult home and hospital medications, and provide updated medication list. Third, outpatient follow-up scheduling. We schedule follow-up appointment with outpatient behavioral health provider and provide appointment details to patient. Fourth, community resource referral. We assess patient needs and identify barriers, provided referrals to community, behavioral health, and social support resources, and we documented resources that were provided. 5, standardized patient education. So we reviewed discharge instructions, educate using teach-back methods, and provided written discharge plan and contact information. 6, patient discharge. So the patient leaves crisis center with the discharge plan, all components documented in the EMR. 7, the 8-week outcome evaluation. So we monitor patient for mental health crisis readmission within 8 weeks of discharge and analyze outcomes and process measures. Again, the goal was this project is to improve care transitions and reduce 8-week mental health crisis readmission. Setting and simple. We talked about it earlier, that this is a quality improvement project and it was conducted at Regional Management Care, which is a behavioral health crisis center that provides stabilization services for adults experiencing acute mental health crises. The project included 154 adult patients who met the inclusion criteria. 80 patients were included in the pre-intervention group and 74 patients were included in the post-intervention group. Only adults discharged during the study period with complete electronic medical records were included in the analysis. Patients younger than 18 years of age and records with incomplete discharge documentations were excluded. So this sample allowed comparison of outcomes before and after implementation of the standardized discharge planning process. And this chart is basically showing you the detailed information that I just shared. All right, moving on to data collection. So, like mentioned earlier, the data for this quality improvement project was collected retrospectively using the organization's electronic medical record. After identifying eligible patients, so standardized data abstraction was performed by using certain criteria to ensure consistency. Okay, we had the demographic information and the discharge process measures that included medication reconciliation, outpatient follow-up scheduling, community resource referrals, all were collected. So I would say the primary outcome evaluated was whether patients experienced a mental health crisis readmission within 8 weeks of the discharge. These data were then analyzed to determine the effectiveness of the standardized discharge planning intervention. Okay, so we're going to continue with the data analysis. The discharge planning intervention resulted in great improvements across all outcome measures. Because the primary outcome compared the proportion of patients readmitted within 8 weeks before and after implementation, a 2-proportion z-test was selected to determine whether the observed difference was statistically significant. Now, the primary outcome showed a reduction in 8-week mental health crisis readmissions from 30.0% before implementation to 14.9% after implementation. This represents an absolute risk reduction of 15.1%, 50% relative risk reduction, and a number needed to treat of 7. So the reduction was statistically significant, as shown, Z equals 2.239 and P equals 0.025. All right, so in addition, the intervention improved discharge process measures because the medication reconciliation increased from 6.3% to 93.2%. That was amazing. Outpatient follow-up scheduling increased from 25% to 73.0%. And community resource referrals improved from 0% to 100%. That was amazing because that's when we really saw that all the patients were getting referred to the right community resources. Together, these findings suggested that implementing a standardized discharge planning process strengthened continuity of care and improved the quality of the discharge practices. Okay, now with all the statistical data that I just went over, this are two graphs showing what we talked about the 30% readmission, the pre-implementation, dropping to 14.9% in post-implementation. So this is just a visual. And in figure 2 is just showing the medication reconciliation, outpatient follow-up, community resources, and the huge gap from the pre-implementation and post-implementation, like the huge increase. So this was a success. All right, we're going to talk a little bit about project limitation. Now, although the project showed significant improvements in discharge planning and several reductions in mental health crisis readmissions, there were some limitations that, should be considered. First, the project was conducted at a behavioral health crisis center, which it could limit the generalization of the findings. And second, it's a relatively small sample size because it was 154 patients, so it may not fully represent other behavioral health population. Third, the outcomes were evaluated over an 8-week period, so longer follow-up could be needed to determine whether these improvements are sustainable over time. Also, the data were collected using a retrospective study. So everything was used from the electronic medical record, making the analysis dependent on the accuracy and completeness of the clinical documentation. Also, because this was a quality improvement project, using a retrospective pre and post design, the findings did show an association between the intervention and improved outcomes, but it cannot establish causality. So if I had to, showcase some limitations, those would be some of the things that we could further discuss and research. But despite these limitations, the finding did provide valuable evidence that the standardized discharge planning intervention was associated with improved outcomes and can guide future practice and research. All right, so discussion. As mentioned earlier, the findings did show that implementing a standardized discharge planning intervention was associated with improvements in both discharge processes and patient outcomes. So, following the implementation of medication reconciliation, outpatient follow-up scheduling, and community resource referrals increased substantially. Okay, so I'd say that strengthened the continuum of care after discharge. These improvements were accompanied by a significant reduction in mental health crisis readmissions within the 8-week period, suggesting that consistent discharge planning can reduce gaps in care and also improve patient outcomes. The findings are consistent with previous literature supporting structured discharge planning and also align with the AHRQ ideal framework, which emphasize patient engagement, medication education, and coordinated follow-up. The intervention was successfully incorporated into the existing clinical workflow without requiring any additional personnel or significant financial resources, which was great because that showed that the evidence-based practice changes can be both feasible and sustainable in behavioral health settings. All in all, with this project, the findings answered the PCOT question by showing that implementing a standardized crisis intervention discharge plan was associated with lower 8-week mental health crisis readmission rates compared with the organization's previous discharge process. All right, implications for nursing practice. I would say this project has important implications for nursing practice. Standardizing the discharge planning process promotes consistent, evidence-based care using AHRQ ideal framework and strengthens continuity of care for patients experiencing mental health crises. Improved medication reconciliation, outpatient follow-up scheduling, and community resource referrals support safer transitions from crisis stabilization to community-based behavioral health services. The project also highlighted that leadership role of DNP prepared nurses is in implementing quality improvement initiatives, translating evidence into practice, and fostering interdisciplinary collaboration. Now, because the intervention was integrated into the existing workflow without additional staffing or major investment, it represents a sustainable practice change that can be replicated in similar behavioral health settings. All right. Conclusion. This quality improvement project showed that implementing a standardized crisis intervention discharge plan did show significant improvements in discharge planning processes and a meaningful reduction in crisis readmission within the 8-week mental health timeline. So I would say this intervention strengthened continuity of care because it improved medication reconciliation, outpatient follow-up scheduling, and community resource referrals while integrating successfully into the existing clinical workflow. If I were to repeat this project, I would expand it to multiple behavioral health crisis centers. I would include a larger sample, extend the follow-up period beyond 8 weeks, and evaluate additional outcomes such as patient satisfaction, treatment adherence, or even emergency department utilization. These modifications could strengthen the evidence and improve the generalization of the findings. In the future, I do hope to continue implementing evidence-based quality improvement projects and initiatives that improve psychiatric care transitions and also reduce preventable mental health crisis readmission. Completing this Doctor of Nursing Practice program has transformed my professional practice because the research helps strengthen my leadership, critical thinking, quality improvement, and evidence-based practice skills. Most importantly, it has prepared me to lead interdisciplinary teams. During this project, I worked with the administrative team and making sure that there was good communication so that way the data that I was using for this project was consistent throughout all the patient charts, since I was dealing with multiple healthcare professionals. Again, I would say this project definitely can translate research into clinical practice and improve behavioral health outcomes. As a doctor of nursing practice, prepared psychiatric mental health nurse practitioner, I am very proud of this project. I want to acknowledge the College of Nursing, Maryville University College of Nursing and Health Professions. I would also like to acknowledge Dr. Rachel Davis. She is my chair. Thank you, Dr. Davis, for all you did. My instructor, all of my instructors. I would like to acknowledge regional management care, clinical staff, my family, and the supporters that helped me in completing this DNP project. These are my references, and thank you for listening. If you guys have any questions, email me. This is my Maryville email. Again, my name is Phalonne Burin. Thank you for listening.